Seniors and dear friends, very good morning. It's indeed a great moment of happiness and pride to introduce my dear teacher and mentor, and MRCP in 19, so for a brief period in Kingdom of Saudi Arabia and later at Meta Multi-Specialty Hospitals. He has been a PALS instructor from 2004, Pediatric Critical Care faculty again from 2004, contributed multiple chapters in more than 20 books, published more than 25 index journal articles. He established the first childhood diabetes clinic in ICH and HC and served children with diabetes from 1999 to 2009 there. He has received many prestigious awards, the Tamil Nadu MGR Medical University Professor K. Sanjeevi Award, Distinguished NBE Alumnus from ANBI, Best Teacher Award from Apollo Hospitals, IMA Eminent Doctor Award in 2011. He has delivered multiple orations, Ayya Nadar Oration in Pedicon 2016, Professor L. Subramanian Oration 2018, Professor B.R. Namalwar Oration in 2021, Professor Santosh Sohn's Oration in 2022, and Professor Thambi Oration in 2022. He has PG teaching experience for more than 33 years, edited and published some of the very popular books like Handbook on Poisoning in 2005, PICU Protocols of Practitioners of IJPP, IAP Clinical Cases in Pediatrics, OSCE in Pediatrics, and he's Emeritus Editor-in-Chief of IJPP. So any resident who has been with Sir, any junior colleague of his, will cherish and remember the time they have spent with him throughout their life. He not only motivates you to learn and be a good pediatrician, but also inspire you with his gentleness and always to be a better human being. A great teacher takes a hand, opens a mind, and touches a heart. Ladies and gentlemen, I present before you Professor Dr. S. Tanguidu.
At the outset, I would like to thank senior teachers, colleagues and friends assembled here, the organizers, and the legend Prof. Krishnamurthy sir, students, and the family for choosing me for this oration. I felt great to stand before you and to deliver this oration. Education is continuously flowing river, no beginning, no end. It's constantly down to the next generation. That is how the education flows like a river. Earlier, we started teaching by observing our teachers. There is no formal. Now it has become more of a science than an art. So, going through some of the books published from the NCP and medical education chapter, I found many things are new. I am also trying to apply them in the routine practice. So I am going to talk about yesterday what I learned, today what I am going to apply, tomorrow what I am going to give the message for the next generation. So I am standing on the stage mainly because I was able to sit in the shoulders of my teachers. I was born at the time when Hardy-Seger formula was introduced in the 1950s, and polio epidemics were managed by iron lung. This is my life timeline. All born in a small rural village for agricultural parents. Our younger days were mainly spent on buffalo riding and swimming in the ponds and rivers. Fortunately there was no amoeba at the time. So my life divided into three parts. First 15 years I worked in rural areas, general practice. Then fortunately had an opportunity to work along with Professor Ramchandran in pediatric intensive care unit in Institute of Child at Madras Medical College, the later part in some time in Saudi Arabia. And after retirement, I am currently working as a general pediatrician and DNV teacher in Meta Multi-Specialty Hospital. So what I learned from the previous generation, from my teachers and my personal experience. When I just finished my CRRI, at that time the professors got a power to give you a postgraduate stage. So Professor Vasudeva offered me a seat because they conduct the interview and select the PG seats. And that is very completely new for those now with less than 50 years age group. So he offered me a seat, but I politely refused, saying that, sir, I got a lot of problem in my family for financial reasons. So what he told me a great concept. He wrote in a paper EARN, and he said, all the 6.5 years you are learning, now you remove the L, go and earn. After earning money, then you come back and add your L. So in fact, that was a prophecy, that was a golden words. Throughout my life I followed that. Learning and earning and in sequence. Later it was converted into learning and teaching. So thanks to my Professor Vasudeva. Jovial sense, we learned why antibiotic may not be of use in diarrhea. I was working in adult pediatric ward during house agency. At that time there was no great medicines are available, only few medicines are available. So Monday, an adult with large amount of large stools, prescription was interstopan and sulfaconazole tablets. Sulfaconazole tablets, those who are younger may not know that sulfaconazole tablet is something like a coat button, twice of the normal size tablets. Monday he told 1 TDS, SDT and 1 TDS interstopan. Tuesday 2 TDS. Wednesday I was afraid to tell him that still diarrhea is continuing. He said 3 TDS. 3 TDS means 9 tablets. I told him, sir, what is the dosage for this medicine? He told, till it completely mechanically blocks the bowel and stops the diarrhea. That's what he said. So I learned that the antibiotic may not be of use in diarrhea, which was reinforced later by Dilip Makhanavis by practicing ORS in 1971 refugee camp. He found it very useful that even the IV fluids and the Lancet certified that the most important medical advance is ORS. Facing a death in the clinic with a bare arm. That is the first death I faced after completing my MBBS. I was doing my private practice. One evening, 50-year-old man came with 3,000 chest pain. As per the medical knowledge, what I heard there, so this could be myocardial infarction. At that time, we used to give Sikul and Analgin to relieve pain and wrote a reference letter to Madurai Medical College. When I was 18, he came to me and said, Thambi means younger brother. They won't even address me as a doctor. Thambi, I am feeling better now. Let me go home. I don't want to go to the medical college. When I am convincing him, he stood up and collapsed in front of my eyes. He died. I could not do anything as a single person in a clinic. Remember, there are no CPR concepts, no ambu bag at the time, no intubation available. I have not seen any ambu bag or laryngoscope during my house surgery days. Only intracardiac adrenal. Which stays in my mind, haunts me in a subtle way. Now I am a BLS, Paul's instructor, and had opportunity to work in PICU, working with dying children. Death teaches a living. When we were in MBBS, in anatomy theatre, we were all young boys. No, we were not very serious about it. So one of my friends was tapping the head of the cadaver and playing music, like tabla. So our Professor Pottusamy sir happened to see that, he became very furious. He did not shout at us, but his look was very powerful and pierced our hearts. He asked us to stand outside the theatre in the veranda for 2 days, no class, no dissection. He told us that, prepare a slogan board reading us, this is a temple where death teaches a living. Still in my sense, in my mind. So alive or dead, patient is my God. Later worked in a remote periphery where there is no bus service, no electricity. Almost about 100 kilometers away from the nearby PHC. And inside the virgin forest, about 50 people had mushroom and then developed diarrhea and vomiting. They were severely dehydrated. They could not be shifted to nearby hospitals. So we went there in a tractor carrying the saline bottles in the buckets. All of them lying down the ground. Tall trees. Of course, human resource was plenty. So I started IV for all of them. One person will hold the 2 IV stand. Like an IV stand, he will hold the bottle for 2 persons. So we were able to hydrate them. After that, I brought back to the small hospital which I was running in the hospital. The whole village was looking at me like a hero. I was only weighing 45 kg like Dhanush, hero, sitting along with the tractor driver. That was the situation. The very interesting part has not come yet. See, these are all the fluid available, but I don't remember what fluid I gave. I don't know 5% dextrose or oxygenous or isolate. I don't know what fluid I administered because I was not given that knowledge during my MBBS or Nausel period. I gave some bottle. Probably all of them recovered, either because I would have given normal saline or God probably permitted them to survive despite my 5% dextrose. Now we realize that is the most important thing. What we need is the management part. Important part should be taught to us during our course. Rather than about degenerative disorders, cerebral palsy, all that. Now day-to-day management practice should be taught to us. So God gave me strength to convert my failure into successes. 1987, I missed one child with, child was on ventilator, newborn ventilated. Child developed bilateral pneumothorax. That X-ray I could not identify. Even my seniors also could not identify. Finally, we lost the child. So that made me to think more about chest X-rays and collected 250 X-rays, different X-rays. I started taking classes for X-ray irritability, which is a very important one. And also one of the faculty for ventilation course for last 15 years along with Dr. Rajkumar in SRM. So I'm just telling you, I'm converting my failure into the successes. I failed my first attempt in MRCP. I went through how I failed. I was failed in OSCE. So we followed waiting OSCEs and we came out with the book on OSCE in pediatrics for PGs practitioners, not only for DNB students but also for MRCP students. That encouraged me to edit a book on IAP clinical cases in pediatrics. Along with nephrology too, we are conducting fluid electrical workshop, almost last for 13 years. So just to stress the importance that everybody should know the different types of IV fluids, what is needed at different occasions. In the same estate, which was a remote one, I had an opportunity to treat a child with tetanus. Usually we carry a bag, go and sit in front of a tree, and then gave injection medicine. That's how we are dispensing medicines. I happened to go and see a child lying down in the hut with opisthotonus and recurrent spasms, tetanus. Tetanus, I was wondering how I am going to treat a remote village. I didn't have enough medicines. I told the manager, usually that the village, that estate, once in a week only a lorry will come, will bring all the necessary equipments, necessary food and everything. He sent someone, with 4 boys he selected and they descended down 3 hours to ascend up another 4 or 5 hours. Within 12 hours they brought all the medicines which I wanted. ATs, antitetanic serum, mefenacin, phenobarbital, lorcatil, everything. Now I can't escape. So fortunately, none of the boy did not develop any complications. Otherwise, for phenobarbital, lorcatil, most of the time they will go in for uplink swells. I didn't even have an ampoupac to treat that. Fortunately, God allowed this to continue as a successful story, and he completely recovered and survived after about 3 to 4 weeks time. So I still remember that when he remember the famous quotation when alchemists know when you want to do something good, whole universe will conspire to help you to achieve it. That's what happened. No ATS reaction, no uplink swells. When I was working in ICU, I will never have that guts of treating a tetanus in a very small village. Because ignorance helps us to do more things. This is the village, Kerala Tamil Nadu border, small shadow. This is the aerial view. This is me in 1970s. I had some hairs and I can use comb also. The boys who brought the medicines, that was Velimala estate in 1976. Then another 3 years work in Kodaikanal Hills. There I realized the need for a pulse course. In the night, an infant was brought to me. I can just read it. OPG, 1 year old, 3 days fever, no convulsion, no breathlessness. This is after I finished my DCH. My knowledge at that time was only 2 infections can kill the child. One meningitis, they will come with convulsions. Another pneumonia, they will come with respiratory distress. So I saw the child was sleeping, none of them was there. So I thought it is a simple infection. I gave paracetamol syrup and penicillin tablets, sent home. Morning around 4 o'clock, child was brought to me with gasping and died in front of my eyes. I could not do anything. I cursed myself, even after finishing DCs in a good institution, I could not anticipate a dying child. I discussed with all the seniors, none of them gave any solution for that. Till I attended the first pulse course. Pulse course only opened our eyes. Some of the PGs sitting the last, can you comment about the patient writing, no OPD writing? What is missing is that nothing is there, no numbers, no pulse rate, no pulse volume, no respiratory, no saturation. That is what pulse starts. Write about pulse, pulse volume, respiration, temperature, blood pressure, level of consciousness. So in 1982, we never structured assessment. In 1994, the first pulse course we had opportunity in Chennai, along with Professor Ramachandran and some of our colleagues. He told us the concept of physiological status assessment, accurate and easy and fast way of structural assessment. These are some of the first encounters, first Pulse course in Chennai 1994. I saw the Abu bag first time, resisted bag in 1981 during my DCH. First ventilator exposure in 1987 and 89. Central venous access 2003. USC CT we happened to meet 1982 and 85. MRI in 2005. And incidentally, today is the day of X-ray discovery. 8th November 1985 by Ranjan. It's a great day. Still is after, even after 120 years, still X-ray is ruling the roost and no other investigation can completely replace it. About Pulse, this slide I like in the Pulse instructor Pulse course. See, if a child comes with URI symptoms, poor feeding and breathing difficulty, previously well child. Probably before Pulse, I will just certify the URI. When you go through the evaluation, identification, intervene, initial impression, first assessment, second assessment, tertiary assessment, diagnosis. Finally, within 10 minutes, I come to a diagnosis of viral myocarditis. Simultaneously supporting the child, treating the child, and identify a very serious illness. That is the beauty of Pulse. I think all of us, how many of us have undergone Pulse courses? Students, can you raise a hand? And even seniors can now participate because MAP program is introduced by Bansal. MAP program is a one-day program. No exam, they can just attend the course, learn the concept and practice. Pulse is a wonderful thing happened in pediatrics in the last probably few years. You are not given any problem with the power to solve it. 1994, I think, first Pulse course introduced in Chennai. 96 we had a dengue epidemic. I don't think that without Pulse assessment, dengue could not have been managed. So Pulse has sharpened our clinical skills. I request all the seniors also to participate and attend the MAP program, that is Mass Awareness Program in Pulse, so that they can understand the concept without writing the exam. So based on this, I just made a video for the practitioners. When a child comes inside, pediatric hospital triangle is assessed. The child is looking at me, I am just trying to treat the child. Child is looking around, so appearance is good, neurological appearance is good. I could count the rate comes to around 32, no retractions. So breathing is normal. I just talk to the child, feel at the feet of the child and feel the dorsalis pedis. I could feel the pulse. Hardly it took only 1 minute. 99% of the time the child definitely does not need hospitalization or any investigation. Doesn't have any serious illness. This is enough to make the diagnosis. So Pulse, the assessment can be applied even in a simple basic clinic. This will be very surprising for you. Great discoveries. Before 1974, there was no scalpel needle. We have to break the needle, connect a catheter and hold with the artery forceps and inside to get an IV access. See, this is the picture. Till 1974. First time I happened to see the scalp incident in one of the private hospitals, I was thrilled and took the scalp incident and showed all my friends that the beautiful device has come. You need not have an artery forceps, you can hold with the wing, and push it, you can see the blood flow coming back, fixing it is easier. Then all the other things followed. Then came vent plans, then came intraocular infections after the Pulse courses, central venous infections, all this came later on. Learning is always fun. Sometimes it's fun. I was working for a short period in Central Ministry. We used to send the statistics to Delhi to the Director General Health Services. After reaching the message suddenly from our seniors and what we were doing, so what is learned from my colleagues today, going through the books about the pediatric education, the terminals are totally different. So I just wanted to apply and see whether it is possible for me to teach them through the case scenarios. So I bought the books and last few days I have been reading about it. So what is clinical reasoning skills and ability to translate unorganized information presented as a complaint by the parents into the language of medicine, accurately assign a diagnostic label and plan an appropriate treatment strategy. The definition looks very complex, but I will tell you the first, after finishing my MBBS, my first patient, I approached him with a lot of interest in the OP and he came to the OP. So I said, this is the first patient, I am going to analyze and diagnose him with lot of whatever the knowledge I heard. So there is an old man, came and sit in front of my stool and said, Tata, what is the problem for you? He said, Garar in Chennai means giddiness. Giddiness was not in my dictionary at all. None of them taught me what the differential diagnosis of giddiness, what investigation I should do, how to treat. I didn't know that. So my first case failed miserably. I felt very unhappy that whatever I studied in 6.5 years could not be applied for the first person. Then one of the lab technicians came and said, sir, you write the blended urine and stool samples, so we'll find something and treat it. So he was also ready to give a stool sample. Stool sample showed hemorrhagesis nana. Again, the biggest problem is there is no medicine for that time, plastic jointed. So that is how my first patient, very miserably I failed in my first patient. So going through that, there are a lot of new strategies has been described in the current medical education technologies, SNAPS model for case presentation, extended matching questions, key feature test, integral problem solving. So I will just try to see how I can apply this in this current case scenarios. This is a 4-year-old girl, 9 days intermittent fever, noisy breathing and voice change, developed right upper lobe pneumonia and treated as OP. 10th day morning, child developed altered consciousness and then brought to the ER. We're looking at the ER assessment form, child has altered mental status, respiratory failure and stridor. X-ray showed right upper lobe pneumonia. Generally, children with stridor usually be very conscious and alert. Audio?
Audio no.
So this is a classical group. The child is got general interaction, but child looking alert. That's what usual thing. So generally, children in the group will not have any altered level of consciousness. If the child has altered level of consciousness, alarm is stated, there are only 3 possibilities. One is hypoxia, but this child's saturation was normal even at the time of coming to ER. Then second is hypercarbia. Blood gases did not show any rise in PCO2. The third possibility thought was a neurogenic stridor. That was the correct diagnosis. Bronchoscopy was done and then child was admitted in ICU. At the time of intubation, the intestine identified bilateral abductor palsy. So then MRI was done. MRI showed T2 hyperintensity, suggestive of Adam, and the child was treated with IV agents. She had completely recovered. I just want to see this case review through the SNAP lens. So what SNAPS is, summarize briefly the history and finding, narrow the differential diagnosis, analyze the differential diagnosis and contrast the possibilities, plan management, select a case related reading. Now we will see this child. 5-year-old had cough, fever, right upper lobe pneumonia, developed altered consciousness, stridor. So what is the anatomical diagnosis? Lung parenchyma, so it is a lung parenchymal involvement. Then child develops stridor, so upper airway involvement. Then develop altered level consciousness. So this is lung, upper airway and sinus involvement. So case continues. Plan airway control. That is the immediate plan. Irrespective of diagnosis, you have to have the airway control. Intubated. During intubation, identifies abductor palsy identified. That narrowed down the possibility of CNS to a brainstem lesion. So what all the brainstem lesion can occur? Encephalitis, vascular lesion, demyelination, tumor, causing vocal cord palsy. So all this, now we come to the conclusion that vocal cord palsy caused aspiration. Aspiration caused pneumonia. And the worsening of the brainstem lesion leading to altered consciousness. Now we are able to connect all the links. So finally the diagnosis is a brainstem problem leading to bilateral abductor palsy, aspiration causing pneumonia, and then because of the brainstem lesion, child had altered level of consciousness. Order for MRI showed demyelination. So plan management is a correct one. Airway control, intubated, child was shifted to MRI in a safe situation. So case related issues in the last case is select the problem and then read further for learning. The case related issues are stridor. Any stridor of the ALC we have to analyze. And safety before evaluation, that is the child intubated and shifted for MRI and brainstem lesion and Adam. So this is how the new strategies probably when we apply it going to be very useful not only for understanding as well as for teaching. This is another child, 2.5-year-old boy. Non-consultant parent, Prof. Rajasthan, fever for 2 days, he had acute onset of failure. So we will look at the SNAP lens. Summarize the history, narrow down the differential diagnosis, analyze and plan the initial management. When he came to here, he had effortless tachypnea, desaturation, acute onset of failure. So what are the key features you identified? He's a boy from Rajasthani origin. Does it give any clue for you? Students and the back bench. So a child with failure in Rajasthani origin, probably hemolytic anemia, I will think, or severe malaria, or even GCPD deficiency. Respiratory rate is 60, effortless tachypnea, saturation 85%, so respiratory failure. But when you give oxygen, the child saturation does not improve. So what does it mean? Either the respiratory distress is very severe going for failure, or non-responding may indicate an underlying abnormal hemoglobins. Failure of acute onset, 2 days you become pale, that's what the father says. So acute onset of failure can occur in either blood loss or acute intravenous hemolysis. And there was a reddish brown urine, hemoglobinuria. When you connect both the pictures, a child with severe failure and dark black urine. What do you think, postgraduates? This is intravascular hemolysis. So hemoglobinuria, intravascular hemolysis. So step by which you identify the key features, you can reach a diagnosis within few minutes. So anemia, hemoglobinuria, this can be caused by intravascular hemolysis occurring in toxins, GCPD, autoimmune hemolytic anemia, malaria, microangiopathy. These are all the differential diagnoses. At the same time, we also identified another issue is pulse oxygen saturation 85%, simultaneous ABG saturation 99%. Does it mean anything to you? Rahul, you could have come forward. Pulse oxygen saturation is 88%, ABG saturation 99%. Does it mean anything? Does it give you any clue? This is called a saturation gap. When there is a saturation gap, that is one point that indicating that there is an abnormal hemoglobin. Probably common hemoglobin, what we see in day-to-day this thing is methemoglobinemia. And then when we inquired, the father said he was found to be handling naphthalene balls. Putting all together, the final diagnosis is naphthalene-induced intravascular hemolysis, hemoglobinuria and methemoglobinemia. You can see the co-optometry showing methemoglobin level as 7.6%. You can see the color of the blood, chocolate brown color, the one in the down, and the upper one is a bright red color for comparison. So when you go methodically, you can come to the conclusion. Acute onset failure, acute hemolysis, low saturated despite oxygen saturation, again point towards abnormal hemoglobin. Hemoglobinuria favors intravascular hemolysis. So what problem can cause hemolysis and with hemoglobinuria same time is probably naphthalene injection can cause both. One more problem the management is what is the contraindication for IV methylene? IV methylene is a drug of choice for methemoglobinemia. What is the contraindication is GCPD deficiency. In the present GCPD deficiency, we can't give IV methylene blue. So finally, we manage the child exit transfusion and completely child recovered. So when you identify key features, probably we can reach a conclusion earlier than what we routinely do it. So the modern method of teaching new technologies in the medical education really helps. Only that initially it's difficult to understand. Second is clinical reasoning, extended matching questions. I have given the differential diagnosis of 7 diagnoses. I have given diphtheria, viral group, corrosive injection, neck abscess, double IT cards, acute epiglottitis and retropharyngeal abscess. The first child is 3-year-old child, URI followed by noisy breathing, low grade fever. This is what a stridor we saw, the stridor. And after giving epinephrine nebulization, completely child record. You can look at the child now, child looks very comfortable. So what is the diagnosis? What do you choose? So viral group B. Okay. So 5-year-old boy, high grade fever, soft stridor. You have to go very close to the child to see whether the stridor is there or not. A croup stridor will be very harsh. This is a soft stridor, drooling of saliva, toxic look and muffled voice. Look at the X-ray neck. What's the diagnosis? Complete air column is obstructed. So epiglottitis. Case 3, 6-year-old child, high fever, stridor, retracted neck and dysphagia. Look at the X-ray neck. I have given the normal X-ray also comparison. This is retropharyngeal abscess. So when do you say retropharyngeal abscess? If the widening of the potential space, retropharyngeal space more than half the size of the C4 vertebrae, it is widening, indicative retropharyngeal abscess. This is retropharyngeal abscess. Infant stridor and tiny neck swelling. Look at the small neck swelling. After incision, we had only 1 ml pus. But that was responsible for stridor. Here, the neck abscess is causing stridor. This is 45 days baby. Baby had a crying spell. Grandmother administered grape water. After giving grape water, the cry stopped, but child developed stridor and became very sick. Ramson was the one who was attending this child when the child was brought to ER. What is the diagnosis? Looking at the lip and mouth. It's corrosive poison. So bathroom cleaning liquid was given in the place of grape water. 7-year-old girl with hoarse voice, respiratory distress and shock, bilateral lymphadenopathy. Child did not receive the second booster DPT. Diagnosis? Diphtheria. 6 months old child recurrent stridor, biphasic stridor. What is biphasic stridor is? Normally stridor is inspiratory, but it is biphasic that shows that the obstruction at the level of intrathoracic upper area obstruction. So from this clue, we did the CT angio which showed double aortic arch completely encircling the trachea and esophagus present in biphasic stridor. So these are 7 case scenarios, and then 7 DDs are given, and we are able to learn all about stridor, a spectrum of stridor cases by using this teaching methodology. So these are all the answers. Group epiglottitis, arch, abscess, neck abscess, double aortic arch, and diphtheria and corrosive. This is the case number 4, clinical problem solving exercise. It's a fictional conversation between the professor and the student around 11:50 p.m. in the night. Good evening, sir. This is a child with pneumonia and pericardial effusion. Chest X-ray and echo done. This is a classical way most of our PGs present. They start with the investigations. So professor asks, how is the child? Lying in bed, sir. How is she? Has fever, breathing fast. You have passed IAP ALS. Why don't you do the assessment as per the ALS and present to me? Yes, sir, I will call again. He takes 5 minutes and call back. So, at least he is able to reorganize himself. The child brought a fever, respiratory distress, previously well child, airway stabilized with positioning, respiratory 70, retractions, grunting present, saturation 85 in room air, 95% after oxygen, peripheral pulses 184, queen responsive, peripheral pulses are weak. This is the video. BDs, what is the sound? Able to hear the sound? So classical grunting. Grunting indicates an impending respiratory failure. Grunting indicates 3 underlying causes, either pneumonia, empyema or pulmonary edema. So these 3 possibilities. Look at the way the nurses are handling. When a child with grunting, it needs only oxygen. So they kept the oxygen mask first and then only they are trying IV. They try IV in the first occasion, child would arrested because of pain and cry. So that's what happened. So now we have the diagnosis. No? X-ray was taken. X-ray showed a classical money bag appearance. Remember this happened in year 2001. Now presently probably they will do focus and identify the pericardial effusion very early. We had a classical money bag appearance. The child initially had a neck abscess and then developed pneumonia, empyema, followed by pericardial effusion. X-ray shows classical features of pericardial effusion. Because there is a money bag appearance, usually the costophrenic angle is usually sharp as pointed in the normal X-ray due to other cardiomegalies. Here it is obtuse and then cardiomegaly. Third thing is any child with cardiac failure, there will be pulmonary congestion. Pulmonary plethora will be there. Here you don't see any pulmonary vessels at all because our diastolic filling is affected. Pulmonary plethora is not there. These features point to a diagnosis of pericardial effusion. Nowadays the focus will identify within few minutes. So because of this, tapping was done in the ear itself, it shows pericardium. So when you go methodically, as per the pulse assessment, definitely it will give a diagnosis even before the investigations are brought into picture. So what I want to, I come to the third part, what I want to leave it for my younger colleagues, the future generation, teaching practical pearls traditionally learned by seniors. Without going through the modern strategies, most of our seniors, we have our own idea of approaching an emergency, approaching a problem, form their own idea. That has to be told to the youngsters. Apart from teaching methods, we should also teach some ethical values. Extra gear, I will explain in the next slide what is extra gear. Use simple analogy to explain complex concepts. When detailed neural examination is impossible, make the child walk and observe. Our professor GK used to say, Oration used to say, detailed neural examination may not be possible very young kids. They may not be able to cooperate, but if you make them walk and observe them, you can make the diagnosis. 90% is equivalent to a detailed examination. History always helps to solve the problem when it is repeated. Making modern education little simpler for us to understand, because even going to the books, lot of techniques are mentioned, the different names. It's very difficult to follow, particularly a person like me in old age. So you can make and discuss with the case scenarios. And the next slides will tell what I want to convey. A lot of machines are there. The machine can give only numbers. They can't connect and give you a link and inference. Only human mind can think orderly and come to a conclusion by clinical reasoning. The computer, all these gadgets will not give more than beyond the numbers. This is a child arrived in deep coma. The child was brought to ICGR at 9:30 p.m. History was 8 o'clock. They were shifting the residence. They are carrying all the utensils from one house to another house. This girl was helping. And when the child came to at 9:30 p.m., decerebrate posturing, bradycardia, bradypnea, shallow breathing, unresponsive, unusual people. So, physiologist said is cardiopulmonary failure, increased intracranial pressure, impending cardiopulmonary arrest. So, airway position, back mass ventilation, IV line, CBG check, normal cell bolus, monitors attached, intubated. Now we intubate the child. This is the time you have to identify the underlying cause. PDS, what do you think? What are the possible causes? Now I stabilize the child. The child came in cardiopulmonary failure, intubated, stabilized. Now we have to think about the underlying cause to treat the primary illness. Any simple strategy to identify the underlying cause? So, any acute onset of altered mental state, there are 6 possibilities. Unidentified injury, unwitnessed diseases, envenomation, poisoning, cerebrovascular accidents, and metabolic causes. These are the 6 causes. When the child comes in emergency, we don't have time to think also. When you have a preformed, clear approach, it will be very easy to come to them. When they ask the mother about any possible injury, any possible drug injection, mother stoutly refused, because child was with me all the time, no injury, no convulsions, no poisoning. Then after stabilizing, we checked the blood sugar 120, CT was done. And above this, from the history, all of them can be excluded except that unwitnessed diseases or cerebral accidents. These are the 2 possibilities we can think. So then after intubation, we plan to shift the child for CT. At the same time, child also developed this sort of lesions. So this is a different child. I am just showing the picture. Normally, lateral margin of the child, the foot will be touching the feet. If it is not touching the feet, there are only 2 possibilities: either fractured femur or PGs. Hemiplegia. So child developed right hemiplegia. Sent for CT. CT confirmed the diagnosis of bleeding with midline shift, probably AV malformation rupture. So cardiopulmonary failure, raised ICP, intracranial bleed, and AV malformation. So these sort of things will be very useful. So usually we might get a child with altered mental state of acute onset with once or twice in a week or a month. So this preformed differential diagnosis will help us to come to the diagnosis very quickly to make quick decisions. When child was done, ventilator support, anti-nerve measures, decompressive clinic was done. Finally, child completely recovered. So methodical approach, good clinical reasoning can lead to the diagnosis and good prognosis. This is a 2-year-old child. I am just coming up with ethical pearls. A 2-year-old child was admitted to abdominal distension. Initially, we thought of suffocating intestinal obstruction. Ultrasound showed a mass lesion. Probably a surgical malignancy, surgical tumor. In evaluating, and the mother also gave this stage that father also had a malignancy. 2 years back he died, and spending a lot of money. And mother refused for further evaluation. She wanted to take the child AMA. We convinced the child. When we were talking, by the time another few hours, child deteriorated, required intubation, shifting to ICU. Child is in ICU and ventilator support. Mother insisting that I want to take the child AMA because I don't want, I can't spend money, because I don't want to see the child suffering. I was talking to her repeatedly, but she was never very stubborn. And finally, in fact, we were very fought with her and said, okay, we are going to take the child AMA. It's almost like killing the child. We forcefully shifted the child to another center where low-cost support will be given. And the child was managed there. Chemotherapy was given. Clearly, malignancy was identified. Chemotherapy was given. This is the blue letters, the follow-up message from the mother. Mother said, hello doctor, I am so-and-so's mother, she is doing well. Thanks a lot for everything. Completed 30-week chemos yesterday, completed last cycle, she is going to school, study EKG, got a prize from the VIP team there. Thanks a lot for your message. How are you? I would like to come and see you. Just by talking to the parents, talking to the mother, otherwise probably would have taken the child home, the child would have died because her own problems. So this is very, very needed in this era where we have to persistently convince them to save the life. Another dilemma we encountered when in ICU, of course in any public sector unit, the need of ventilator will be less compared to more compared to the availability of ventilators. So in ICH usually we will have some 6 or 7 ventilators with 15 beds. So one baby is extubated or baby dies, that ventilator will be started on another child who requires ventilation. But generally we don't have any preference. We will put the child on ventilator as per the time of admission. So there is one baby extubated, 24 hours kept the ventilator. After 24 hours the ventilator is ready to use. Next in the line is a child who is a brain dead child. Child came with in a CNS infection and child is a brain dead child. Morning we will counsel the child. That is the next child in the list. That is also referred by one of the ministers. Then the second in line is a child with snake bite, respiratory failure with 2 to 3 days of ventilator support will completely recover. So it's a dilemma. So Professor Ramachandran was there, close to the hospital. He went to the hospital in the night, talked to the father. How did we resolve it? Talked to the father, told the father of the brain dead child, told him that morning itself we told you that our child has almost lost all the vital signs, he may not survive. So even if you put a child on ventilator, because as per the order only your child will get a ventilator. The child will not survive. At the same time, next child, snake bite, with the child on ventilator, after 3-4 days completely will recover. So only when you give concurrence only we can put the child ventilator with the other child. So the father, it seems, he only told, with tears in his eyes, he said, I don't know what sin I committed to lose my son. I don't want to commit more sins. So let the ventilator goes to the child who really deserves it. That is what. That is the ethics. So we have a great role to play. So after talking to the parents himself come to the conclusion and said, whatever, wherever you want me to sign, I will sign it. I don't want a ventilator for my child because my child cannot be saved in any instance. So let it go to the deserving child. So these are all the ethical pearls we should taught our students. Child with repeated vomiting. Generally, abdominal cause, systemic cause were ruled out. So the child had repeated vomiting, 2 weeks, no seizures or loss of consciousness. Mother, when you asked the mother said, whether your child will be walking around. Yes sir, from 10 months on, my child was running around. Now she is clinging to me. She doesn't want to get down out of here, get down and walk. That was the speech she gave. So abdominal examination was normal, ultrasound was normal, LFT, RFT normal. So we wanted to do a complete neural examination for the child. But the child was clinging to the mother. She never wanted even, I can't even touch her. So how are you going to do a complete neural examination? So there is no way we can do the complete serious examination. So what I did was, we waited outside the room and told the father, the child may not walk in our presence. Let her walk. You take a video and show it to us. We were waiting outside. This is the video. This will be a lesson for the PTs. So look at the video and comment. What is he here? The mask identity I covered the face. So it's also not recorded well in the bright sunlight, bright light. Comment about the walking pattern. Comment about the gait. PGs in the last seats. The child was walking very well, running around, now walking like this. Ataxic gait. The MRI was ordered, MRI showed a big tumor, medulloblastoma. So, these are all very small, simple tricks. Now, otherwise, without seeing an examining, child would have gone home, may come back in a coning state and may even die. So, when you are unable to complete neural examination in a child, at least make the child walk. This will give you a lot of clue about the power, tone and cerebral functions. We always stress about the clinical skill. Even there was a debate in the morning, clinical skill or the equipments. Both are needed. In our days, no, we used to do peripheral smears even during the admission days. Urine routine, stool routine, peripheral smear, everything we have to do it. So, may not be doing everything, but there are some simple bedside investigation a student should be familiar to make a quick diagnosis. He is Mr. Michel, he's a sports psychologist. He introduced a new terminology called extra gear. When an athlete is running, he is unable to compete with other person. He says, you develop your mental strength and develop a new skill which we may not be able to do it. So beyond your ability, you create a new skill. That's called extra gear. So here I want just to tell the students that if you are able to read and interpret an X-ray chest, that will give you an extra gear. If you are able to look at a peripheral smear and if you are able to identify an important finding, that is an extra gear. Look at an ECG and you can make up very important finding in emergency, that's an extra gear. We will see in the next few slides how it will be going to help you. This child, 2-year-old, brought in ER, gasping, shock, hypotension, desaturation. The speaker fell over the child. Look at X-ray quickly. It's a point of care investigation. Bilateral pneumothorax. Bilateral pneumothorax, you can see the image, air is shifted. So child was, ICD was done on both sides, child completely recovered. So what saved the child was a quick identification of bilateral pneumothorax without any delay. So point of care investigation we must be familiar. This child came with afebrile seizures, unconscious child, fundus was normal, CT was normal. Anything else? Can you identify a cause for seizures from the X-ray? X-ray shows a clear diagnosis, which was not identified by CT. This lead poisoning, you can look at upper and humerus, metaphyseal dense bands, look at the constant junction showing a white deposits. Even manubrium sternum can be seen. Manubrium sternum also can be seen with white deposits. All the features suggestive of lead poisoning. So after identifying lead poisoning, now we have a management which can save the child. You can just compare the normal upper end of humerus which doesn't have the metaphyseal dense bands. 2-year-old child, acute onset of cough, respiratory distress, sibling was eating ground. A classical history of a child with foreign body ingestion. Findings, hyperarid left hemithorax, mediastinal shift to right, bronchoscopy markings. So if you are able to identify, X-ray can be identified, quickly you can involve bronchoscopies or call the ENT surgery and remove the foreign body and save the child. 6 weeks old girl, child, grunting, fever and abdominal distension, no blood in the stool, tachycardia, tachypnea, bounding peripheral pulses, no gallop. Child had grunting. Again, grunting reason is pneumonia, empyema, pulmonary edema. These are 3 reasons. X-ray was taken. X-ray doesn't show big pneumonia, empyema or cardiomegaly. What are the findings you identify? In adult, usually to identify air in a diaphragm, you have to make the adult stand up for the older child. But it's an infant, we can't make them stand up. He will be in a lying down position. There you must be able to identify the pneumoperitoneum. Look at the X-ray. You can see that normally the liver density, that is a normal one. Liver density marked by right streaks and blue one is heart. Liver and heart density will be same density. Look at the abdominal one. The liver density is little hypodense, mixed density. This shows that there is an air present. This is peripheral peritoneum, pneumoperitoneum. Unless the pneumoperitoneum is identified, then this child would not have been saved. And again, if you look at the abdomen also, any child is shocked with abdominal distension, more likely possibilities, abdomen is the pathology reason for this. Again, CT, this in fact, unless the radiologist is oriented towards pediatric CTs, they might miss this finding. This is a classical finding seen in non-accidental injury where you can see the dense interhemispheric fissure. Other one is a normal but thin line. You see a thick, dense interhemispheric fissure posterior side. That's the classical feature of non-axial injury with collection of the blood in the posterior interhemispheric fissure. Unless the neurologist, pediatric oriented, the radial pediatric oriented, this finding may be missed. If a general pediatrician knows this background, they can identify and contribute to the cause. Child 3 months old, respiratory distress, systolic movement, desaturation. Just by identifying the Q waves, you can make the diagnosis of Al-Kappa. Nothing very big. If you identify Al-Kappa, you can call the cardiologist earlier and can proceed with the surgical management. You can identify the Q waves in lead 1, AVL, V5, V6. So all these are basic investigation. Some important finding we are able to remember, identify, this will fast track the investigation and quickly we can reach a specialist consultation and confirm the diagnosis. 5-year-old boy present with diarrhea, puffiness, edema, urine at district or college hospital in a DRP program, like district research program. There the lab technician made a smear. You look at the smear, you can make the diagnosis. This is a normal smear for comparison. What is liquid circle is what you identify there. This is very simple investigation. You can see the fragmented RBs or blood cells, HUS. So you can make a diagnosis of HUS even in a DRP program, even in a small center. This is doesn't need anything very big. So you can make the diagnosis. Now you can refer the child to a higher center to manage the child. 5-year-old limb pain, failure, diagnosis. So how do you differentiate a lymphocyte from the blast is, normally in a normal lymphocyte, the cytoplasm will be more than 50% of the circumference. You can see the cytoplasm all around. Here the cytoplasm which is there in the cell is only less than 1/4. This is a blast cell. So unless you have seen the earlier during your course, we might miss it. All these are pattern reading only. If you've seen the blast cells during your course, probably you will not miss it. You can identify blast cells even in the rural centers or peripheral areas. You can identify fast and refer to a hematologist so that the outcome will be good. We had one lab technician, usually he's a very good technician. He used to call before he closed the lab. Those days, no lab will not work 24 hours. He called the ICU and said, there is a child admitted with hepatosplenic jaundice. We were thinking of hepatic failure. 4 o'clock before closing, he called us and said, sir, none of your PDs came in to collect the report. This child's peripheral smear shows falciparum malaria. See how the prognosis changes. Hepatic encephalopathy prognosis will be bad. If you identify falciparum malaria with autism, child will completely recover. This again you can make the diagnosis by looking at the peripheral smear. So I request all the postgraduates once a week, Friday, usually lean days, go to the lab and see all this peripheral smear finding, which you can, once you can see that probably pattern reading will fix you the diagnosis. This is a classical banana shaped gametophytes and double chromatin route of falciparum malaria. OSCE is a wonderful way of teaching as well as for assessing. It's an excellent method of examination. Not only educative, but also promotes critical thinking. This is a 10-year-old boy referred as status epilepticus from another nearby medical college. So he initially presented with status epilepticus, anticonvulsants, ventilated for 5 days, then extubated. By 6th day, after extubation, he developed convulsion. We are re-intubated and referring the child to us. So we were thinking that we are going to receive a child with HSV encephalitis complications. But in the second hospital, when we prepared, when we were shifting the child in ambulance, the resident who went there said that, sir, he is showing the thumbs up sign out with the parents and asked the history. The 10 minutes of time we spent with the parents were wonderful. That gave the diagnosis. So child came with the spasms, intubated, ventilated. After extubation, again he developed spasm, re-intubated and came to us. When we sat with the parents and asked the history, this is the history. Monday morning, the boy was getting ready to go to school. After sending him to school, the parents wanted to go for a marriage. But the boy realized that and he also wanted to come along with them to the marriage. So he refused to go to the school. He came with the parents, they went to the marriage hall. The marriage hall he developed convulsions and then you know the history. What is the missing link? So we talked to the parents, we sat with the parents talked to the boys who were playing with him in the marriage hall. What happened was, he went to the marriage hall. Marriage hall, he was with other classmates, friends, he was running around the marriage hall, eating groundnut, laughing, crying, shouting. So missing link was, we were running here and he developed upper area obstruction. He developed tonic spasm because of hypoxia. Went to the hospital, decided as tonic seizures, intubated, ventilated. After extubation again he was given, when he was breathing, the foreign body shifted back into the trachea, developed second spasms. So only the history gave us a diagnosis. All of the investigation, nothing gave us a diagnosis. From the history, we identified that it's not a CNS bronchitis, only respiratory issues. Bronchoscopy was done, identified a lot of foreign body particles, and ENT surgeon removed it. So, the repeat history was very useful. So, apart from all the gadgets, history, when you repeat, when you don't have any clear clue, repeated history will give a clue, and then finally we are able to save the child. We can use simple analogy to explain complex concepts. No fluid compartment, most of them will not remember the numbers. So 2/3 of the earth is made up of water. So human body also follows Mother Earth. So 2/3 is total body water, that is 65%. 1/3 of it is ECF 20, 2/3 is ICF 40. Among the ECF, again 1/3 is plasma volume 7 and ISF is 13%. So by just giving simple analogies, they can remember the complex concept of various fluid compartments. Whenever we teach hyponatremia, even brain students will fail. A child with hyponatremia, what will be the problem in the brain? Most of them will say in hyponatremia there will be cerebral edema. So that is not correct. So we just use a simple analogy. We call it as verdumanga. In South India, it's a very popular pickle. A round verdumanga is put into the salt water, so it shrinks. So similarly, in hyponatremia, brain shrinks. You put a hard, small rice, put it in water and simple salt, it bulges out. So in hyponatremia, there is cerebral edema. In hyponatremia, there is shrinking of the brain. So simple analogy will be helpful to teach them to understand the complex concepts. So coming back to the last slides, the teaching practical pearls traditionally learned by general pediatric teachers will be useful, like any child with autism mental status have some 6 differential diagnoses, we can come to a conclusion. Teaching method, ethical values, extra gear is a peripheral smear, ECG or chest X-ray. Simple analogy to explain the complex concepts. When a detailed neural examination is impossible, make the child walk and observe. History always helps to solve the problem. What was thought as a recurrent neurological problem is happened to be a respiratory problem causing air obstruction. Making modern educational skills a little simpler. Probably all the new strategies like new concepts, new technique of examination can be coupled with case scenarios so that it will be better understood. So I am just standing here in the stage just because I was sitting on the shoulders of my teachers. There are so many teachers. So let us continue to learn and teach and transfer the concept, what we learn from our teachers and from our experience to the next generation. Thank you very much for your patience.
The words have beautifully carried the legacy of the oration, humility as well as deep commitment to medical education. Now may I request our dignitaries on the stage, Dr. Nirmala ma'am and Chair and Dr. Vishnu Mohan to please come forward, as we would like to felicitate sir as well. And also the dignitaries of the stage, Professor Prof Gupta sir, Dr. Ramchandran sir, Dr. C.P. Bansal, Dr. Harish Pemde sir, Organizing Chairman Dr. Ajay Ward sir, our Superintendent Dr.
Really humbled to see you all, sir.
Wonderful, sir. Very fantastic, sir. Thank you. Thank you.